Hello, and thank you for joining us for another LVS webinar. Today, we're going to talk about the radiographic features of bone tumors and bone infection. So for those of you who are new to these webinar sessions, just a very brief introduction. My name is Ian Jones, and I'm a radiologist. I graduated from the Royal Veterinary College in 2004. I got my RCVS certificate in veterinary diagnostic imaging in 2009, and I got my European diploma in 2018. If you need me, then this is where you'll find me. I'll be at London Veterinary Specialists, which is a multidisciplinary referral hospital in the very heart of North London. If you have any questions at all about anything imaging related, if you have some radiographs that you feel that you might need a little hand interpreting, or if you'd like to have a chat about what imaging modality might be most useful when you're working up a complicated medical or surgical case, then please feel free to give me a call at the clinic or drop me a line via email. For those of you who have listened to our previous webinars, you should now be familiar with this textbook. So this is Veterinary Diagnostic Radiology by Donald Thrall. This is the textbook that I used most during my imaging residency, and it comes very highly recommended. If you have any interest at all in learning more about veterinary diagnostic imaging, then I would recommend purchasing this textbook and becoming very familiar with it, just as I did during my imaging residency. This presentation is based on a chapter taken from this textbook, chapter 17. So occasionally when we're looking at a radiograph, we'll see an area of bone that doesn't look quite right. And once we've decided that this bone is abnormal, then the question that we usually ask ourselves is, this bone lesion that I've picked up, is this an aggressive lesion or is this a non-aggressive lesion? And there are a few things that we need to look at and decide upon before we can be confident about classifying a lesion as either aggressive or non-aggressive. So we need to look at the cortex adjacent to the lesion. And if there's evidence of cortical destruction, then that's very significant. We need to look at the periosteum around the lesion. And if there's a periosteal reaction, that's also something to take note of. And we also need to pay attention to what's known as the zone of transition. So the transition zone, the boundary between normal bone and abnormal bone. And how clear is that zone of transition? Do you think it is short and distinct or long and indistinct? And all those characteristics can help us decide whether a lesion is aggressive or non-aggressive. So let's take another look at those radiographic features and see how they differ between aggressive and non-aggressive lesions. So an aggressive lesion is going to have cortical destruction, whereas a non-aggressive lesion is much less likely to have any evidence of destruction of the adjacent cortex. An aggressive lesion is going to have an active periosteal reaction, and more often than not, that periosteal reaction will be irregular, whereas a non-aggressive lesion is much more likely to have no periosteal reaction, or if there's a periosteal reaction there, it'll be a more regular or smooth periosteal reaction. Aggressive lesions are going to have a long, indistinct zone of transition, so it should be extremely difficult for you to tell where the lesion starts and where the lesion ends if it's an aggressive lesion, whereas a non-aggressive lesion is going to have a short, distinct zone of transition. So the boundary between the normal and the abnormal bone should be very short and very clear for a non-aggressive lesion. There are some exceptions. So for example, there are some benign lesions that can cause pressure necrosis. So a nasopharyngeal polyp, for example, that's expanding beyond the boundaries of the bulla can sometimes destroy the adjacent bone. And that could be interpreted as cortical lysis. So as for everything in medicine, there are exceptions. But if we remember this table and we stick to these rules, then we're not going to go far wrong. Now, it's very important to remember that in order to classify a lesion as aggressive, only one of these features needs to be present. So you don't need to tick all the boxes. If there is evidence of cortical destruction, then chances are it's an aggressive lesion. If there's an active irregular periosteal reaction, then chances are it's an aggressive lesion. If the transition zone is long and indistinct, it's likely to be aggressive. These features in isolation are enough to classify a lesion as aggressive. So only one is needed. So let's start by having a little look at cortical destruction and think about how we can classify it in a little bit more detail. So if you see cortical destruction, then there's a couple of different ways that it can be described. So when we talk about cortical destruction, we tending to talk about bone lysis, so loss of bone. And that loss of bone can be described as either geographic or moth-eaten or permeative. So let's take a look at some examples and discuss the differences between these different sorts of lysis. So this is it's a dorsopalmar view of a canine carpus, and hopefully you can appreciate that there is some focal loss of bone at the level of the distal ulna just here. Now, this area of bone is quite clearly marginated and has a short, distinct zone of transition. So this is an example of geographic lysis. So here we have a medialateral view of a proximal humerus, and we've zoomed in at the level of the proximal metaphysis. And hopefully, you can appreciate that there's an area here of moth-eaten lysis, as evidenced by numerous areas of poorly marginated, almost punctate lucencies. So this would be an example of moth-eaten lysis. Here we have a medialateral view of a canine femur, and again we're zoomed in this time at the level of the distal metaphysis. And what we can see are a number of features that are compatible with aggressive bone disease. But what I really want you guys to focus on here is the fact that we have multiple areas of lucency that appear to be coalescing. So we have coalescing regions of ill-defined bone destruction, and that's compatible with permeative lysis. There are some other features here as well, so there's certainly some evidence of cortical destruction and a periosteal reaction. So this lesion is looking highly aggressive. Moving on to the periosteal reaction and the different types. Broadly, we can describe them as either being regular or irregular, and if a periosteal reaction is regular, invariably it'll often appear smooth. For irregular periosteal reactions, we can describe them using terms like spiculated or columnar. That doesn't really change how likely or unlikely a lesion is to be aggressive. If there's a periosteal reaction and it's irregular, then it's more likely to be an aggressive lesion. But it's nice to be able to classify these types of irregular periosteal reaction with a little bit more confidence. So here we have a medialateral radiograph of the mid-femoral diaphysis of a dog, and we have this really exuberant, smooth, raised periosteal reaction on the diaphysis. Now, because this is a more regular periosteal reaction, our initial impression might be that, well, this lesion could be a benign lesion. However, there is a periosteal reaction. It is quite exuberant. Even though it's smooth, it is accompanied by this area of moth-eaten lysis at the level of the mid-diaphysis. And the fact that we've got lysis and the fact that we've got a periosteal reaction means that this is more likely to be an aggressive lesion. And this patient, unfortunately, went on to be diagnosed with an osteosarcoma. Here we've got a medialateral view of the distal humerus of a dog, and what we can see on the cranial aspect of the distal humerus is this very irregular periosteal reaction. And hopefully you can appreciate that this periosteum is raised, and there are multiple focal areas of raised periosteum that almost look like little columns. So this is an example of a columnar periosteal reaction, sometimes referred to as palisading. I think columnar is more appropriate, given that these little focal areas of raised periosteum to me look like little Roman columns. So this is an example of a columnar periosteal reaction, and again associated with aggressive bone disease. Here we've got a mediolateral view of the distal radius of a dog, and we have a really highly irregular, exuberant periosteal reaction on the cranial surface of this distal radius. Now, this periosteal reaction is extending sharp little tendrils into the adjacent soft tissues, so it almost looks spiky. It's so highly irregular, and this is an example of a spiculated periosteal reaction. Now, there are a whole number of other changes to this bone compatible with aggressive bone disease. So we've got a very long indistinct zone of transition. We've definitely got some lysis affecting the mid-diaphysis here, and some cortical destruction, and a huge amount of soft tissue swelling. So this is looking like a really highly aggressive lesion. So we've talked a little bit already about the zone of transition. So is it distinct or indistinct? If it's distinct and short, then it's much more likely to be a benign lesion. If it's indistinct and long, then it's much more likely to be an aggressive lesion. So let's maybe take a look at some examples of some distinct and indistinct zones of transition. This is a mediolateral view of a carpus. This is the same lesion that we looked at previously to demonstrate geographic lysis. And again, we can see this focal area of radiolucency at the level of the distal ulna. And again, we've got this very sharp, distinct zone of transition. So this focal area of radiolucency, and then normal bone surrounding it. And we can see the boundaries between the lesion and the bone very clearly. So this is a short, distinct zone of transition, has very clear margins, and this is something that you're more likely to see with a benign bone lesion. In contrast, we have got a lateral view of a distal femur, and again, there's a whole manner of features that are compatible with aggressive bone disease here. There's permeative lysis, and we've got this raised, highly irregular periosteal reaction, and potentially some evidence of cortical destruction as well. And the thing to take away from this radiograph is that the zone of transition is impossible really to see. So I mean, if we look at the level of the mid-diaphysis, you can think, well, is this normal bone here? And at what point does the normal bone become abnormal bone? So here we can be pretty confident that, I mean, it looks like there's some permeative lysis affecting the diaphysis here, but where do we get from normal to abnormal? So it's really impossible to tell. So this lesion has a very long, indistinct zone of transition, and that's often associated with aggressive bone disease. Once we've classified a lesion as aggressive using all of those features that we've just discussed, we then need to decide whether it's more likely to be something neoplastic versus something infectious. And if it's neoplastic, invariably, we're usually looking at a primary bone tumor, like an osteosarcoma. If it's related to metastatic disease, then that's also a type of bone neoplasia. That does differ from primary bone tumors like osteosarcomas, in that metastatic disease tends to be polyostotic, whereas primary bone tumors tend to be monoostotic. And we'll have a little bit more of a chat about those in just a second. If it's infectious, then is it a bacterial osteomyelitis or is it a fungal osteomyelitis? There are other sorts of osteomyelitis but in the UK, it's almost always bacterial, very, very rarely fungal, but we don't have the same sort of infectious organisms that are present, say, in the USA, that can result much more commonly in a fungal osteomyelitis. So we'll have a little chat about what sort of organisms might be responsible for a fungal osteomyelitis in the UK and what sort of dogs might be affected by it a little bit later. We'll start with what's most common, and certainly the most common reason for diagnosing a monoostotic aggressive bone lesion in the UK would be a primary bone tumor. So a primary bone tumor, like an osteosarcoma, for example, almost always it has a metaphyseal predeclination. So you're going to find them affecting the areas of the metaphysis of the bone. So canine osteosarcoma's most common type of primary bone tumor, and they have a bimodal distribution. So canine osteosarcomas tend to affect young animals and old animals. So unfortunately, young animals that have monoostotic aggressive bone lesions at predilection sites for osteosarcoma, so towards the stifle or away from the elbow, they are definitely out there, and you shouldn't be put off by the age, because, like I've said, canine osteosarcoma has a bimodal distribution. So young dogs and also old dogs, less likely dogs that are effectively middle-aged. So bimodal distribution for canine osteosarcoma. So let's take a look at an example. So here we have a lesion affecting the distal metaphysis of this femur. It's effectively towards the stifle, so very close to the stifle joint. So this is a predilection site for osteosarcoma. There's numerous areas of bone lysis and lucency that are coalescing. So we could describe this as a permeative lysis. We certainly have some evidence of cortical destruction. So the margins of the cranial and the caudal cortex are somewhat effaced, and there are areas where we're losing the density of that cortex. So there's certainly some evidence of cortical destruction. And we've got this associated periosteal reaction, which is quite irregular on both the cranial and the caudal aspects of this distal femur. The zone of transition is difficult to see, so it's long and indistinct. So this lesion is metaphyseal. It's at a predilection site for osteosarcoma. There's evidence of permeative lysis, cortical destruction, an irregular periosteal reaction, and there's an indistinct long zone of transition. So this is absolutely an aggressive lesion, and top differential would be osteosarcoma. Feline osteosarcomas are the most common primary bone tumor in cats. I've not seen as many feline osteosarcomas as canine osteosarcomas, but there's certainly plenty of patients out there that are going to present with osteosarcoma. Feline osteosarcoma is not bimodal, so you tend to only really see it in older cats, and you tend to see it more in the hind limbs versus the forelimbs. And unlike canine osteosarcoma, which commonly will metastasize to the lungs, feline osteosarcoma, pulmonary metastasis is much less common. So still most common primary bone tumor in cats. You're more likely to see it in older cats, so it doesn't have a bimodal distribution like canine osteosarcoma. You're more likely to see it affecting the hind limbs in cats, and you're less likely to see pulmonary metastasis in a cat that has osteosarcoma. So again, let's take a look at an example. So we've got a mediolateral view of a stifle. We've zoomed in again at the level of the lesion, which here is at the proximal metaphysis of this tibia. Again, we've got these large coalescing areas of radiolucency that likely represent lysis and destruction of the bone. We have indistinct cortical margins compatible with cortical destruction. The zone of transition here is a little bit easier to see relative to the canine osteosarcoma that we saw a moment ago. So this zone of transition is shorter and clearer than the previous example. And we've also got this periosteal reaction. This structure here could represent an avulsion fracture of the tibial crest as a result of this lesion affecting the proximal tibia and this proximal tibial metaphysis. So this could be a pathological avulsion fracture of the tibial crest. So in terms of the features of this lesion, it's at a predilection site for primary bone disease like osteosarcoma. It certainly has evidence of permeative lysis, cortical destruction, and a periosteal reaction. Now, we only need to find evidence of one of those features in order to classify it as an aggressive bone lesion. So this is an aggressive bone lesion. This is an osteosarcoma in a cat. For metastatic bone disease, the main difference between it and a primary bone tumor, they're both going to look like aggressive lesions, but primary bone tumors tend to be monoostotic, so there's only one bone affected, whereas metastatic bone disease is going to be polyostotic. So there's going to be multiple lesions affecting multiple bones. However, they still have a predilection for the metaphysis. The types of tumors that tend to metastasize the bone are epithelial tumors, so carcinomas originating from the mammary glands and the lung, the liver, the thyroid, the urinary system in general, and the prostate. They all can metastasize to bone. So if you have a patient that you know has a mammary carcinoma, for example, then certainly bone metastasis should be on the list of things that need to be ruled out, and that applies also to patients with things like thyroid carcinomas and prostatic carcinomas. So let's take a look at an example. So here we have a radiograph of proximal femur and also the stifle of a dog that has multiple myeloma. And we can see aggressive bone lesions affecting the proximal femur and also the proximal tibia in this patient. These lesions have similar characteristics. So there's evidence of permeative lysis, there's evidence of cortical destruction, there's a periosteal reaction in both locations, and the zone of transition is relatively indistinct and quite long. So there are multiple aggressive lesions affecting multiple bones. So this is a polyostotic aggressive bone disease, and this is an example of a multiple myeloma. For patients that have bacterial osteomyelitis, so aggressive bone disease secondary to infection rather than neoplasia, it can affect the bones in two ways. Either it can get there via the blood, so hematogenous spread of bacteria, or the infection can be introduced as a result of some sort of local trauma. Again, the lesions are going to appear as aggressive, and for bacterial osteomyelitis and osteomyelitis in general, it's more likely to have a columnar type periosteal reaction. However, this doesn't apply to all lesions, but more often than not, bacterial osteomyelitis will have an irregular periosteal reaction and it'll look more columnar-like. So again, let's take a look at an example. So here we have a mediolateral view of a tarsus, and this patient has had a tarsal arthrodesis performed. And hopefully you can see that on the plantar aspect of this calcaneus, there's a very irregular periosteal reaction. And again, we've got these focal areas of raised periosteum that look like columns. So this is a columnar periosteal reaction on the plantar aspect of this calcaneus. Now, not only that, but we also have some focal areas of lysis associated with the tips of these most distal screws and also potentially around this bone plate. So this is an example of a patient that has bacterial osteomyelitis as a result of its surgery. So this is a nice example of a columnar periosteal reaction as a result of a bacterial osteomyelitis. So fungal osteomyelitis, it is a differential, and it should be on your list of differentials. If you have a patient that has evidence of aggressive bone disease, you certainly don't see it very often. And in the UK, you're much less likely to see infectious osteomyelitis than you are if you are living and working in the United States of America. However, there is a condition called systemic aspergillosis in German Shepherds, which has been described. And as a result of this systemic fungal infection in these dogs, you can get things like discospondylitis, and you tend to get a polyostotic aggressive bone disease. So you'll see multiple aggressive lesions affecting numerous bones. And there are dogs out there with this in the UK. It's not very common and not very well known. So it's worth keeping in mind that German Shepherds can get systemic aspergillosis, and that can manifest as a polyostotic aggressive bone disease. So here are some images taken from a paper that was published in the Journal of Veterinary Internal Medicine back in 2008. And hopefully you can appreciate that this patient certainly has evidence of multiple aggressive bone lesions, so polyostotic aggressive bone disease. And we can see them affecting the scapula, and also affecting the humerus, and also the femur. And these lesions have all the characteristics that we'd expect from aggressive bone disease. So there is evidence of lysis, cortical destruction, a periosteal reaction, and also a fairly indistinct zone of transition, particularly affecting this lesion present on the scapula. So, I mean, what I want you guys to take away from this is that systemic aspergillosis in German Shepherd dogs does exist. It's very uncommon. You do sometimes see it in the UK, so it should be on your radar if you have a German Shepherd dog that you take some radiographs of and it has polyostotic aggressive bone disease. It could potentially be systemic aspergillosis. So it's not uncommon for us to take radiographs of the digits, and oftentimes we're chasing a diagnosis either of something infectious versus something neoplastic. So does this patient have an osteomyelitis of the bones of its digit, or could this be something more sinister? Could it be something neoplastic like a squamous cell carcinoma or a melanoma? And the reality is it's extremely difficult to tell the difference between the two. So we're able to pick up features compatible with aggressive bone disease that might be affecting the bones of the digits, but it is really hard to comment on, well, I can see evidence of aggressive bone disease here. Do I think it's more likely to be neoplastic disease, or is it more likely to be osteomyelitis? Really tricky to do that, and often you need a biopsy in order to be sure about whether or not the etiology is something infectious like an osteomyelitis, or it's something more sinister like a squamous cell carcinoma or a melanoma affecting those digits. So before we finish, we'll just take a look at a couple of clinical examples. So these are cases that I've come across during my time on clinics, both during the residency and afterwards. The first case is a 10-year-old female neutered giant schnauzer that presented with a history of acute onset right hind limb lameness. So we have two radiographs to evaluate. We have mediolateral and caudocranial views of the right stifle. Hopefully you guys can see that the region of the proximal tibia is very abnormal, and it's abnormal on the lateral aspect. And it's abnormal because the radiopacity is reduced. So I think we can describe this as moth-eaten lysis of the lateral tibia, and it extends towards the lateral tibial epicondyle. There is some evidence of cortical destruction here as well, and the zone of transition is long and indistinct. What's curious about this proximal tibia, particularly in this caudocranial view, is this little fissure line here. So it looks like we have a closed, complete oblique intra-articular fracture, which is on the lateral aspect of this proximal tibia that extends distally and laterally, eventually bisecting this lateral cortex. And as a result of that, we've got this single, large, roughly triangular bone fragment, which is slightly displaced proximally and laterally. There are a few other changes as well. So there's certainly an increase in opacity of this stifle joint and cranial displacement of the fat pad and associated soft tissue swelling. So the soft tissues around the stifle joint look larger than they should look. So our conclusion is that there is monostotic aggressive bone lesion affecting the lateral aspect of this proximal tibia, and there's an associated, what's likely to be pathological fracture of the right tibial epicondyle. And this lesion was indeed neoplastic, but actually this was an example of metastatic bone disease. So this patient unfortunately had a primarily ocular melanoma that had metastasized to its proximal right tibia. So that's a nice example of an aggressive bone lesion secondary to metastatic bone disease. Case number 2 is a 7-year-old female-neutered German Shepherd. It's recently had a TTA, and that happened 4 weeks ago, but despite that, it's been persistently lame. So again, we have mediolateral and caudocranial views of the stifle. And if we look closely, we can see that there's a radiolucent halo associated with this metallic cage implant and the associated screws. We can see some other changes as well, more likely related to chronic joint disease. So there's some osteophytes at the level of the apex of the patella and on the trochlear ridges, and also on the tibial plateau and this lateral epicondyle. There is some increased opacity of the stifle joint and potentially some cranial displacement of the fat pad. But what's most significant is this radiolucent halo associated with this cage implant, and that was confirmed as being secondary to an osteomyelitis that's occurred as a result of this surgery. So this is an osteomyelitis associated with this cage implant that's been used during this TTA. So case number 3, which is the last case. So we have a 13-year-old female-neutered domestic short-haired cat that's lame on its right hind. So we've got mediolateral and caudocranial views of this stifle. Hopefully, you guys can see that there is increased opacity of the caudomedial aspect of this right proximal tibia. And if we look at the fine detail of the bone that's at the level of the mid-diaphysis versus the proximal diaphysis and metaphysis, there is some loss of trabecular bone detail here that's compatible with lysis. The zonal transition is pretty indistinct. We can potentially see a very faint boundary, but it's difficult to know where that stops and where it starts, particularly in this caudocranial view. If we look very carefully at the medial aspect of this proximal tibia, we can see that there are a few little areas of punctate lysis of that cortex. So there is some evidence of cortical destruction, and there's a little wispy periosteal reaction on the medial aspect of this proximal tibia, particularly caudally in this mediolateral view. There's also some soft tissue swelling associated with this lesion. So this lesion, it's classified as aggressive. So there are some features here that are compatible with aggressive bone disease. So the permeative lysis, the cortical destruction, the irregular periosteal reaction. And we only need one of these features to classify a lesion as aggressive. So we can be reasonably confident that this is an aggressive bone lesion. And biopsy of this lesion was compatible, or at least highly suspicious of, an osteosarcoma. And this is just a nice example of how osteosarcomas can sometimes look predominantly proliferative rather than destructive. So there's a whole range of different appearances for osteosarcoma. Sometimes they're highly destructive and there's a huge amount of lysis of the bone associated with the lesion. Other times they're a little bit more proliferative, and in areas it appears there's maybe more bone than you'd expect to see. So the bone is more opaque than the adjacent unaffected bone. And I think this is a nice example of that. Okay, so that's all for now. Hopefully you have enjoyed this webinar on bone tumors versus bone infection. I hope everybody stays safe, and I hope to catch you all again during our next webinar. Thank you very much for listening. Bye-bye.